So I'd like to transition to, I think, one of the key abstracts, two key abstracts, and that was this real-world data, because I found this tremendously exciting. What did you guys think of that data?
I thought it was one of the best presentations at ASH 2018. I may be a little bit biased as we contributed some cases to it, but I think that it showed that people want to get together and really learn across institutions and continue to put out the data that gets this continued CAR T cell to be growing from that standpoint. But the data was very interesting because if you looked at it, I'm trying to remember off the top of my head, but I believe 40% of the patients would not have been eligible for ZUMA-1, and the results looked fairly comparable, almost uncanny comparable to the ZUMA-1 population.
Right.
Yeah, I think they put together 300 patients in one abstract, 100 or something in the other abstract. So I found almost 400 patients with real-world experience, and a large number of those were not eligible for the clinical trial eligibility criteria, which I think, again, is the key factor, because that's the art of medicine, is translating from an FDA approval, which just says twice relapsed large cell lymphoma, to actually then who do you actually treat? What else struck you guys on those?
So I think some of the reasons why they were not eligible helps with our real-world experience. They did take some patients who had slightly poor performance status. They had patients whose end organ function didn't meet the exact criteria. So from a renal standpoint or from a cardiac standpoint, those things stood out. I think it really, but overall, it really appeared to mirror what was seen. Now, they did see a trend towards slightly worse outcomes for people who didn't meet those strict eligibility criteria, but it still was really good. The other thing which struck out is there were a significant number of patients on a separate presentation above the age of 65 who also seemed to have just as good responses as the below 65 population, which hopefully increases the access to patients who are above 65, and also the toxicity did not seem to be much worse. So we've all treated patients who are in their high 70s or even up to 80, and while we are worried so much about CRS and neurotoxicity, as you pointed out well before, that majority of this is reversible, and even in the real world experience, we are not seeing deaths, too many deaths. It was actually very similar to what was presented in ZUMA-1 in terms of deaths, knowing that even in real world outside of clinical trial, majority of these toxicities are reversible if we are allowed to use aggressive measures to treat them.
So I think the key points: CAR T cells cause problems with fluid that leads patients to be intubated, so you don't want to start them hypoxic. CAR T cells cause renal problems. CAR T cells cause neurologic problems and potentially heart problems. So those patients have all been screened out of any CAR T cell protocols. And what we don't know is what comorbidities are really no-go for CAR T cells and what comorbidities are okay. And just like what we've had to do with transplant, we have to figure out the level of comorbidity that patients have to, the good level that they need to be at in order to safely give these.
Right. And we do have a sense of that with transplant, but we're not yet clear on what to do in the CAR.
Those studies need to be done.
But even transplant is a bit of an art, right?
It is.
I mean, it's because there's transplant centers that are more aggressive than others.
But there are clinical trials trying to look for that in sort of a border between a person who may not be eligible for transplant, but potentially eligible for CAR T. Juno has a study which is looking at that.
Right.
But I think what these retrospective experiences have at least put out to the oncologic community is that the relapse refractory lymphoma population, age shouldn't define whether or not you could get a CAR T cell. If you don't have CAR T cell at your institution, trying to get that person to an institution that has CAR T cell available, whether it's commercial or clinical trial, and at least have the discussion about CAR T cell, I think is appropriate in 2018, especially coming after ASH 2018 data.
So it seems clear to me that we need to get this therapy to more patients. And the other point that came out of these talks was that if you actually had less disease, and you then would have a better outcome, and you seem to have less toxicity. And this was from analysis of the ZUMA-1 trial, and it seemed to be echoed across some of the real-world data as well. So I think if we could get these patients to treatment before they just have massive disease that's refractory to everything, we could even improve on these outcomes that we're seeing in the clinical trials. The second point I think that was key was that the ZUMA-1 trial did not allow bridging therapy of significance, where in the real-world data, that was the major reason why people would have not been eligible for the ZUMA-1 trial, that we had to do something to keep them alive to be able to give, while the cells were being manufactured. And to me, I think that shows that those people did as well, and I think that's going to be a key going forward.
I think there is still a true art in that bridging chemotherapy too, because on one hand, those patients are progressing very quickly, but if you give them something that is potentially, going to set them back hematologically or a high infection risk, without much benefit in the disease, because these people are coming in triple refractory, to R-CHOP, rice, GemOx, bendamustine. So you have to be, in some ways, still choosy, but a lot of us are trying to find less intensive regimens and convincing the patients and their caregivers that this is the first time where stable disease and acceptable kind of performance status, that you're not getting that ECOG migration where you're having a 1 becomes a 2 or a 2 becomes a 3 because of the chemotherapy that you've chosen to get the lymphodepletion. But what that data also showed me is that we're actually getting good at this a little bit of choosing what that lymphodepletion chemotherapy may be. It may not be the full dose of bendamustine. It may be a little bit lower dose, and so on and so forth, to tease out and the right timing after apheresis prior to lymphodepletion.
One thing that we really need to look at as we look at patients earlier in therapy is the quality of the T cells going into the procedure and the exposure that those T cells have had to various types of chemotherapies. There's a number of studies that have shown that very significant chemotherapy can affect T cells, and you get a type of T cell population where the CARs just don't work very well. And we're not very good at identifying the right mix of T cells, and I think as studies move forward and we use a little bit earlier on, we may find better responses just because there's better T cells.
Right. One of the things actually thinking about the differences between the study, I think the ZUMA studies required a certain number of T cells to be present, a certain ALC, whereas the Transcend study from Juno really didn't have that requirement. So again, we can't compare cross studies, but I think that's something we need to look at as we go forward with this kind of treatment.